Hello everyone. This is Prosthodontics on Friday, which explains about different steps of implant prosthodontic treatment on live, and I'm MC Dr. Cho In-ho. These days we're experiencing sub-zero weather, although it is November, and Professor Park Sang-won from Jeonnam University has come to Dental Studio despite such a weather. Professor Park is renowned for providing prosthodontic treatment for edentulous patients. Today, he's going to give a lecture under the title, Effective Implant Prosthodontic Treatment for Fully Edentulous Patient. This program is proceeded live and you can raise your questions on YouTube and we'll answer them. I would love for a lot of you to participate. Now let's welcome Professor Park Sang-won. Greetings, I'm Professor Park Sang-won of Jeonnam University. Today, I'm going to talk about effective implant prosthodontic treatment for fully edentulous patients. The contents are as shown. Let's talk about edentulous patient first. At school, I teach about full denture, so I always talk about edentulous patients. In general, still, in the elderly population from 65 to 75 globally, approximately 20% is fully edentulous. Among age group over 75, approximately 30% are fully edentulous. In 2014, according to US CDC, approximately 20.3% of those between 18 and 44 are fully edentulous. Let's look at some figures in Korea. Let's look at the figures presented by Ministry of Health and Welfare. Approximately 2 million people of those over 75 are fully edentulous. Implant treatment is very important for full denture patients. It is very difficult to provide satisfactory treatment with just a full denture, as shown in the image. There are many difficulties in a lot of patients. Therefore, we come to use implants. The implants used for full denture patients can be divided as fixed and removable types. Fixed can be divided as fixed restoration and fixed detachable denture, and removable can be divided as implant-assisted RPD and implant over denture. Let's look at each in detail, looking at the fixed restorations first. This is what patients want most, a fixed restoration. You need to provide treatment in the same way as crown and bridges, and one of the most important things to consider is the anatomical structure of the patient. In other words, the residual alveolar bone. Whether the patient requires bone graft or not is also one of the biggest issues. A second is how many implants are necessary to support the prosthesis. The economic factor cannot be overlooked. These are what people consider most. However, I think people often miss the aesthetic factor. This is the image of my patient. The patient received the full implant treatment and prosthesis from local clinic. In the anterior aesthetic area, lip support was lacking, so aesthetically the patient was very unhappy, and she came to the university Functionally, it is okay, but you need to consider the aesthetic aspect as well to provide the good treatment. Bone resorption was very severe and ridge augmentation was required. However, the patient just wanted fixed restoration, and I provided fixed restoration because the patient felt really strong about it. When the patient came to me, the patient was 52 years old. From late 30s, the patient had been wearing full denture for approximately 15 years. As shown, ridge was very resorbed. After the patient started to use full denture, she just locked herself inside and did not engage in any social activity. The patient insisted she wanted fixed restoration. I tried to persuade her, but in the end, I let her have her way and provided such treatment. Iliac bone was used for bone graft and implants were placed and fixed restoration was provided. The patient was very satisfied. Aesthetically and functionally, she was very satisfied. She said that it's like regaining control of her life. She talked about going to meet her friends and going out on parties. There's a bit more story to it, so I'm going to talk about this later. Apart from whether or not bone graft is needed, you also need to consider how many implants are required for fixed restoration. The images that are displayed have been randomly selected from Google. These are the screenshots from local clinic ads. All on 8, all on 6, all on 4 is possible according to these ads. And all on 4 is all the hype these days, and a lot of lecture it focuses on all on 4. However, if you look at the literature, regardless of whether you do all on 8 or all on 4, the success rate is similar. If you look at the details, this can differ slightly in terms of maintenance. Let's assume that there's a single implant failure on all on 8 or all on 4. The way we do maintenance and address complication is different. How many prostheses do we use it? What kind of design do we use? I think we need to focus on maintenance when we make these decisions. The way forward is for easy and comfortable maintenance. The number of implants being placed have decreased significantly compared to early stages. As shown in this slide, this case was done by myself in early 2000s. At the time, it was a trend to place a lot of implants. In severe cases, some people argued that you need to place an implant per root, and over 10 implants were placed to restore fully edentulous patient. However, these days I recommend all on 6. So up to first molar, 12 implants are suggested. I try to divide into sections so that it has a design that is retrievable. I focus on repair and maintenance. The most effective treatment allows for good maintenance. Second is fixed but denture type. Fixed detachable denture. This is also called hybrid. This design has been shown when Dr. Bronemark first introduced implant to us. And this was repeatedly used even up to this day. It is still being used today. We have to restore the resorbed alveolar bone, so pink soft tissue needs to be restored in one way or other, be it resin or porcelain. This is necessary to get aesthetic result. Aesthetic and cleansing. There are colliding concepts here, so there are difficulties. When we do this kind of design, especially in the maxilla, there are many difficulties associated with cleansing. This case was also done in early 2000s, and because of these concerns, I tried using milled bar. Implants were placed at the time. In prosthodontics, electro-gold plating was all the hype, and milled bar was created using titanium. Gold plating was added after consultation with the patient. When possible, I try using pin attachment. If you use this, the patient can take them out using their fingernails. And once it's fixed, it does not move like a fixed restoration. Although there was severe bone resorption, aesthetically and functionally good results were achieved in this case. Such attempts were made in this case. In order to achieve aesthetics and cleansing, these designs should also be considered once in a while. Let's talk about removable prosthesis. First is implant-assisted removable partial denture. I think this design is most frequently done within Korea. The reason is, in our national insurance, for those above 65, 2 implants are allowed, and crown needs to be there, and natural tooth also needs to exist for insurance to apply. Because of such regulation, this design is used extremely frequently in Korea. Overdenture cannot be applied, so this design is used. I prefer splint bar in this design. 2 implants are placed, and splint bar is used to connect them to create partial denture. Using such design, the patient can receive insurance and also get rather satisfactory result. One of the cautions we need to take is that accurate prosthesis with the correct size and shape fitting this denture needs to be created. It is more complicated than overdenture, and in aesthetic area, clasp can be noticeable, so it's not popular with a patient. If overdenture can be insured from patient and for surgeon perspective, it will be preferred over other options. Under current insurance conditions, splint bar overdenture is very efficient and attractive option. Next is implant overdenture. This is the same. The biggest issue at hand is how many implants are going to be used to support overdenture. The first is, depending on the number of implants used, the design of the restoration or attachment can be decided. The most frequently used attachment is bar or stud attachment. And there are others like telescopic crown or milled bar or magnetic. But in general, people choose bar or stud attachment, either of the two. This kind of denture is created. In lower, how many implants should be placed? In McGill consensus and York consensus, 2 implant-supported overdenture is the first choice standard of care for edentulous patients. First choice is to use overdenture using 2 implants, and you are already fully aware of this. Next is 1 implant overdenture. A lot of literature introduces this, and it does have somewhat good success rate and patient satisfaction rate. 3 or 4 implant overdenture and lower. In terms of patient satisfaction, just because implant number increases to 3 to 4, the patient satisfaction does not necessarily increase accordingly. However, in the case where retention is of importance, this is recommended. In lower, the number of implants to be placed, one standard is to use 2, and depending on patient's economic condition, you can use 1 or 2 or 3 or 4. These could all be good options. What is the ideal number of implants to be placed for maxillary overdenture? There's no established consensus for this, and there's no accurate scientific evidence. In maxilla, there's no set standard. However, a lot of literatures say that if you use a splint bar using over 4 implants and do overdenture in maxilla, you get predictable results. In maxilla, splinted paw overdenture is frequently used. Using less than 4 implants comes with uncertainty. There are a lot of case introductions, but data is still lacking, and it does not have any evidence to prove that it is predictable. So in the upper, there is still a lot of work that lay ahead of us for us to have a clear understanding. Next, let me compare fixed and removable dentures. Let's focus on literature. I looked at review paper on patient satisfaction on fixed and removable, and I also looked at papers on success rates, and I've organized them. First is survival rate. The survival rates for fixed and overdenture are both quite high. However, if you compare them one-on-one, fixed show higher survival rate. For overdenture, if you use more than 2 implants in the lower and 4 implants in the upper, the success rates are higher. Regarding bone resorption, let's look at crestal bone resorption. Overdenture shows more crestal bone resorption compared to fixed. In the case of overdenture using more than 2 implants in lower posterior, mandibular ridge resorption occurs significantly. Regarding masticatory performance, the results were gained via a survey to the patients. In 8 out of 11 researches, there was no major difference in masticatory performance between fixed and removable. As for the remaining 3, it says that it is better in fixed. In terms of maintenance, removable is more favorable. However, there are more prosthetic complications in removable, and it is easier to repair compared to fixed. Regarding cost effectiveness, removable is more cost effective compared to the fixed. Finally, when we look at the overall satisfaction of the patient, when we compare fixed and removable, over half says that there's no major difference, and the remaining half says fixed is a slightly better. As shown here, out of 8 studies, 5 say that there is no major difference between fixed and removable, and 3 say fixed is slightly better. In a different study, for approximately half of it says there's no difference between fixed and removable, and the other half says fixed is slightly better. One says that removable overdenture is better. We can conclude that both removable and fixed show very high patient satisfaction rate. When we look at these results, in terms of patient satisfaction, fixed is slightly better than removable, but there's no major difference. Let's look at the changes in restoration type looking at clinical cases. So this is a case where removable was changed to fixed. This patient was 60-year-old male patient. 4 implants were used and overdenture was provided. The patient used it for approximately 10 years. And after a decade, there was wear in the bar and retention decreased. And one day he came and said he wanted a fixed restoration. We added 4 more implants and changed the restoration to fixed type. The patient was very satisfied and even to this day continues to use it. This is a female patient in her mid-50s and she received ITI implant, 4 of them, in the anterior region from a local clinic, and it is early ITI implant. It is supragingival implant and overdenture was created. The patient used it for 10 years. Now that she's in her 50s, she had more money in her pocket and she wanted to change it to fixed restoration. When she discussed it to the local clinic declined because maxillary sinus was pneumatized and the clinic recommended a university hospital. And she came in and we added more implants and we provided treatment like this. The early ITI implant, it comes out supragingivally like this. So fixture along with abutment had to be prepped to restore the case. Most people prefer fixed to removable, but there are sometimes people who prefer removable compared to fixed. This is the first case that I've shown you, and originally I provided fixed restoration. The patient was very happy. The patient went out to eat meet and hang out with friends, and the patient was very happy for about a year. And after that, the patient came back. For aesthetic reasons, fixed prosthesis was slightly bulky. And the patient expressed a discomfort and wanted to take them out once in a while and complained that oral hygiene was very difficult to maintain. The patient wanted to receive overdenture. I suggested against it, but the patient wanted it and the patient is continuing to use the overdenture. Using 4 locators in upper and 4 in the lower, overdenture was provided. The patient is very happy functionally and aesthetically and is continuing to use overdenture. I gave the patient the option of choosing between the 2. It has been approximately 5 years and the patient is continuing to use the overdenture. So the clinical photo for the next case has been lost. The patient received treatment from a local clinic in Yosu and she lived in an island. She received a fixed prosthesis, but after she got them, she got severe headache and she was not able to sleep and it was of huge discomfort and there was trouble with the local clinic and she was accompanied by a family member when she came to our hospital. I made a temporary fixed prosthesis for the patient, thinking it had something to do with the neutral zone or the contour of the tooth. However, the patient came back within 2 days and she wanted them out and she wanted a denture. I tried to persuade her to continue using them for like at least a couple of days or a week, but she insisted that she needed them removed. She received overdenture instead. These two patients were the most unique out of all the patients that I treated. I think these kind of patients, they have been using full denture for a long period of time, and because they have had such experiences, they prefer removable type. This case is a very heartbreaking case, and at times we see these kind of cases. In 2000s, the patient was 68-year-old at the time. The patient suffered diabetes mellitus, and in lower, fixed restoration was provided in the upper. Conus denture was used. The patient used them for 10 years, and after that, diabetes became more severe, and the patient did not come in frequently. And as a result, as shown, all of the natural teeth and implants were lost and full denture had to be used. This is a truly heartbreaking case. For patients with systemic disease, the starting point is important, but continuous care up until the final point is very important, and that is why I included this clinical case. Requirements for effective prosthodontic treatment. This is the final part of the lecture. For fixed prosthesis, the biggest advantage is that it is fixed. In general, patients prefer fixed restorations. There are many shortfalls and challenges associated with it, such as anatomical difficulties, and multiple surgeries may be required, and it can be quite expensive. Additionally, treatment time is quite significant. Despite all that, some patients still prefer fixed. Removable prostheses have many pros compared to fixed. It doesn't require bone graft. Oral hygiene, aesthetics, it's very favorable, it's cost effective, and it has low risk. However, the biggest shortfall is that it's removable. It's very efficient, however, it's removable, so that's the main disadvantage. What I want to say is that there are many pros and cons of fixed and removable restorations, and we can discuss them with the patient, but the most important is the patient preference. As a dentist, we are responsible to meet the patient demands and consider patients' anatomical conditions, provide an opinion as to what kind of prosthesis is most predictable and ideal for the patient. To me, that is the most efficient prosthesis. This is the end of my lecture. Thank you. Nice to meet you. Please sit down. Professor, I've enjoyed your lecture. Thank you for coming all the way here for Prosthodontics on Friday from Gwangju. I used to teach alongside you, so it's a great honor. How did you like providing lecture today here? Online lectures have become more frequent due to COVID, and this is one of the nicest studios. It's very nice. I've been to a couple of TV studios, but I think it's really one of the best. Thank you for giving me the opportunity to provide a lecture in such a nice studio. Thank you once again for inviting me. I'm honored to be here on the same stage as you, Professor Cho. I've always looked up to you. I'm sure there's a lot of catching up to do between us, but because of time constraint, let's move on to the Q&A. I'm sure a lot of people have a lot of questions. First question. For fully edentulous patient, we can provide fixed and removable restoration. When we provide a fixed restoration, what kind of problems are the most difficult to solve? I'm interested in your opinion. I think the toughest prosthodontic treatment is to provide full arch fixed prosthesis. I've mentioned this in my lecture, but you need to consider the anatomical constraints and determine how many implants you're going to place. In my opinion, the most difficult part is around the aesthetic zone. There are not that many cases where there's sufficient bone to create aesthetic result, and I think that is the toughest challenge that we face. When there is severe alveolar bone resorption, there's only so much we can do, like providing crown. In terms of lip support, there are at times very unsatisfactory results. I think you need to do diagnostic wax-up ahead so that you can predict the results beforehand, and that is the best way moving forward. And I think that is one of the biggest challenges. Especially for older female patients, lip support is important. If it is wrinkly and shrunken, patients do not like that at all. Sometimes, even when you provide prosthesis, the patient may reject it because of that. When you provide fixed restoration, you cannot adjust the thickness of the flange, so lip support and aesthetics is one of the most important factors. Second question. In the case of implant retained overdenture, what kind of attachments do you use and prefer to maintain the implant? I refer to a lot of literature and I just follow what the paper tells me to do. In the case of maxilla, I prefer bar over denture, and in the case of lower, I use 2 implants and separate it like this. O-ring or locator are used. Various attachments, I have used them as well. In the past, I used to use bar over denture, but these days, I use a stud attachment and locator the most. I think that is the safest way. In the papers that I've looked at, comparing bar and stud attachment, the patient satisfaction is higher in stud type, and a lot of papers say that. For bar type, the cleaning is an issue and it's difficult to find the right path, and there are multiple problems. There's also a question about the current situation we're in. The national insurance covers 2 implants for patients over 65, but overdenture for fully edentulous patient is excluded. I major in full denture, and so do you, and this is sort of heartbreaking. In the case of lower, if you just place 2 implants, patient would experience much less discomfort and live on much more comfortably. What is your opinion on that? I concur with you, Professor. Implant for overdenture needs to be insured as soon as possible. I'm sure a lot of people have more experience than I do, but there are many elderly population who experience difficulty due to full denture. There's anatomical limitations, so no matter how well you do it, it's quite difficult. I live in the rural regions, so there are more such patients. In the past, I used to be in charge of insurance at Prosthodontic Association, and I negotiated full denture with the government, and after that, Although I did not engage directly, there were negotiations with the government over partial denture and implant. I provided my opinion based on my previous experience, and at the time of implant negotiation, from what I gather, reimbursement for fixture and crown separately was negotiated. However, overdenture was not successfully negotiated. As a currently working dentist, whenever I go to the association, I raise this issue. I will urge the managing directors once again so that overdenture can be included in the insurance. I often say that. I look forward to that day. Your support will be deeply appreciated. More so than the dentists, patient opinion is important. When we were negotiating with the government side also mentioned this. Patients need to express their desire. They need to raise their voice to the Korea Consumer Agency or Ministry of Health and Welfare in order to expedite the process. More than the opinion of dentists, from the government perspective, the general public and the beneficiaries' voice would be more hard to ignore. There's a question coming in. In the upper, number 23, number 24, in the symmetrical position of natural tooth number 23 and number 24, in other words, number 13 and 14, IARPD, implant-assisted RPD. What is the prognosis in doing this? Is symmetry an important factor in doing IARPD? Implant has progressed significantly compared to the early days. And implants are almost as strong as natural teeth these days. In line with such tendency, not just full denture patients, but for partial denture patients, IARPD is used frequently. Sometimes I use IARPD for the patients. As mentioned, factoring in symmetry into the treatment. I think this is a kind of case that is being done frequently. I think sufficiently good results can be gained if all conditions are the same. I think good results can be gained. About symmetry, the importance of biomechanics have been emphasized over and over again. In that sense, symmetry is very important in prosthodontic treatment. Asymmetry can be very problematic. Scissor bite can be a problem. Symmetry is one of the most important factors. I think this has been sufficient in addressing your question. Let's move on to the next question. I would like to ask about treatment option for a patient with edentulous ridge in the upper and on both sides, no first and second molar in the lower, whether to do implant on the lower molar and do maxillary full denture, or to do overdenture, or whether to go with lower RPD. Can I see the front part? So the maxilla, it's edentulous, and for mandible, the teeth only exist up to premolar. What kind of treatment options could be applied for this patient? Placing implant in lower molar, so bridge type, cubics type treatment will be provided, and whether maxillary full denture is going to be done on the maxilla or overdenture, or whether RPD should be used on the lower. I think the question is whether to do maxillary full denture or use RPD. At times, maxillary full denture, in the case of times, it can be okay. If the masticating force is not that strong, that can be okay, and you can do implant in the lower and maxillary full denture. This is not recommended, but it still can be an okay option. However, if the patient has strong masticatory force, it will not last and fracture would occur, and this can haunt you later on. One of my interns had a similar case, and fixed prosthesis was added in the upper in the end. People with strong masticatory force, you have to factor that in. In my case, if the patient has strong occlusal force, rather than maxillary full denture, I would design overdenture. And it is better to place 4 rather than 2 in the upper. If the patient's economic condition does not allow it in the upper, I would do overdenture, and lower, I would do RPD. In terms of biomechanical balance, that could be a nice option. In terms of treatment cost, the most economic option would be to do partial denture in lower and do full denture in the upper, followed by doing partial in the lower and overdenture in the upper. And then the next option would be to place the lower with implants and do bridge and overdenture in the upper. You need to consider patient's economic condition. I think this addresses your question. You're very popular with questions today. I have one more question for you. A lot of people use Magic 4 or All-on-4 or other implant fixed hybrid denture clinically. But I fear for the prognosis and I feel hesitant about making such an attempt. What is your opinion on this? I don't have experience on All-on-4. Honestly speaking, one of the main reasons is because of maintenance, and that is why I have not made such attempt. There are people who lecture on this, and they talk about many advantages of All-on-4, about how success rates are very nice. But there are also people who argue the contrary. If one goes wrong out of the 4, what's going to happen, they say. And they talk about patients coming in with problems associated with this. I personally have no experience about it, so it's difficult to give you my definitive opinion. But personally, I feel in terms of maintenance, I do not recommend it. As mentioned, I prefer placing 6 implants, separating them and dispersing them so that even if one side breaks down, the patient will still be able to function using the rest. All-on-4, if one goes wrong, sometimes you need to remove the entire thing. That is my opinion. In Osstem, Magic 4 is available now. In my opinion, in the case of All-on-4, you need to consider what the antagonist is like. You don't really do All-on-4 on the upper, you do them on the lower. If it is All-on-4, you would have them place the implants in an angled manner like this. If the antagonist is full denture and if the masticatory force is not that strong, it's possible. But if it is sound and if there is a strong masticatory force, you need to be careful. Because of time constraint, we will end the Q&A session. You have many pupils, Professor Park. And do you have any words of advice for your pupils or your peers studying implant prosthodontics? I'm sure everyone is doing great. And today's theme was full arch. When you do full arch prosthesis, always, you need to do diagnostic wax up and consult with your patient sufficiently and predict the treatment result ahead. You need to provide treatment accordingly with the anticipated result. That is the best treatment. The word of advice I have for my pupils: you need to study sufficiently so that you can predict the treatment results ahead, and you need to do your best so that you can get the anticipated results. After that, you can attempt providing treatment for full arch, and you need to also care for your patients. You need to think in the shoes of your patients. I think you have, because of the time limit, you did not mention it, but you're very renowned in digital denture. I apologize for not giving you sufficient time, and next time maybe you can address that. You have talked about rehabilitating fully edentulous cases right now, but next time maybe we can talk about digital full dentures. Thank you. Based on the opinion of fellow dentists, one of the most tricky areas to treat is fully edentulous ridge. And I believe that you have addressed a lot of the concerns that a lot of the dentists had regarding treating fully edentulous patients. Thank you for your support and your input. It's time to end the live prosthodontics on Friday. Even if you've missed the beginning, don't worry too much. If you access the dental site, you'll be able to see the prosthodontics on Friday, which was aired today from start to finish, and you'll be able to see various contents, and I'm sure you'll be able to get useful information. The next prosthodontics on Friday will air 2 weeks from now, and it will be first in its series in addressing problems after implant treatment. Professor Park Chun-jin of Gangneung Wonju University Prosthodontics Department, who is renowned in this area, will discuss about the cause and solutions for screw loosening of implant abutment. Thank you for watching. Thank you.
감사합니다.
네, 감사합니다.
고맙습니다.
아이고, 감사합니다.